morning. My name is Manal Zaabi. Today I'm going to present a case about a child with papilledema. So I'll start with the case presentation. He's an 11 years old boy. He's a known case of skeletal dysplasia, which is characterized by short statures, osteoporosis, and multiple fractures with delayed healing. Patient he is on growth hormone treatment in 2014 for 8 months. But then we stopped the growth hormone because he found to have papilledema. Papilledema was on and off since 2015, and he was treated with Diamox. An investigation for his papilledema, we did MRI for him, and it showed that patient has optic disc canal narrowing. So in clinical examination, he's in regular follow-up, and in clinical examinations, which was in April 2019, patient has no complaint, and he was off the Diamox and the growth hormone. The vision was 6.6, and color test was normal, pupil examination was normal, and the anterior segment examination also was normal. But the optic disc swelling showed that the patient has a blurry margin, which is minimal, considered as papilledema grade 1. But at this visit, we did not decide the patient to start the Diamox, and we advised the patient for regular follow-up. But the mother did not come for the follow-up, and in November 2019, the patient came, and his papilledema getting worse. Although the vision was 6.6, pupil was normal, color vision was normal, but as we show in the picture that the papilledema is getting worse. So we asked the mother for detailed history, and we found that the child started again the growth hormone 1 month ago. Actually, the mother, she's keen on starting the growth hormone because her child has short statures. His height is 129 centimeter, and he's considered below the first percentile in his age. So she was worried about his psychosocial development, as the impact of short statures had emotional, behavioral problem, low self-esteem, and her child is being bullied in his school by his peers. And in the future, she was thinking about have less marital success, low job satisfactions. But on the other hand, if we keep the patient on growth hormone and he has a chronic papilledema, the patient will have optic disc atrophy, and he may have visual field defect and lose his vision. So we explained the mother the risk of continue the growth hormone, but she's really want to continue the growth hormone. So for this situation that her child is really considered very short and he's been bullied in the school. So I want to ask the expert, what is the best plan for this patient? Shall we continue growth hormone, stop the growth hormone, or reduce the size, reduce the dose of the growth hormone?
Okay, so to summarize, this is 12-year-old boy, known case of skeletal dysplasia, with on and off papilledema, and recently he developed
the growth hormone again 1 month ago, and his papilledema getting worse.
So I'll watch closely. If mother really keen, I will refer to neurology for starting Diamox, acetazolamide, and I will watch him very closely.
Yeah, thank you for this interesting case. I think there are two potential causes for the disc swelling in this child. One is the growth hormone. Rarely growth hormone can cause increased intracranial pressure. But the other is this skeletal dysplasia.
Yes.
Have you had a good look at the optic canals in this patient? I saw an MRI, but you know, if there's narrowing of this is not showing the bones. I mean, I'm concerned that there's narrowing of the canals that could be causing the disc swelling.
Yeah, it is one of the risk factors, but after 1 month of restart the growth hormone, his papilledema getting worse. This is the before, and this is after.
Well, first I would want to get some good bone images to make sure that narrowing of the optic canals is not the cause of disc swelling in this patient, because the child is at risk for that. So once that is ruled out, and you do feel that there is an association with the growth hormone, because rarely growth hormone can cause this, and the mother wants to continue it, you could, with the work with the endocrinologist, give the lowest dose possible and follow clinically to see how low you can go without, and follow the discs very carefully. But first you have to make sure about there's no bony abnormality, because this child has a disease of bone fragility.
Yeah, so you've really got to exclude osteopetrosis, basically, and that you can do that with an MRI or a scan of the optic canals. And if it's that, then you're in big trouble because, okay, you give him a bone marrow transplant, I think is one of the treatments for it. And then, the decompression, I've had a few of these, it doesn't work very well, and it's a big procedure with huge number of potential risk factors. The other differential, as you said, is benign intracranial hypertension, secondary. The one thing about, in my experience over time anyway, is Diamox is very safe in children, and you can use Diamox long-term without any great side effect in children, as distinct from maybe adults. And the other factor, of course, if it persists, you'll have to probably consult your neurosurgical colleagues for a shunt. No, if it's not osteopetrosis, if it's the other differential diagnosis, then you can't go on with probably a papilledema like this. If Diamox isn't working very well, you'll have to do something more long-term. The kid has no headaches.
No, he has no headache.
Which is a big negative factor in terms of benign intracranial. I mean, in my experience, anybody with benign intracranial has quite a headache. These kids get very severe headaches.
Thank you.